Okay, so when we talk about orbital diseases, they usually arise from within the bony confines of the orbit, or they may spread from adjacent structures such as your sinuses. So etiologies often in orbital diseases include inflammation, infections, and neoplastic or metastatic etiologies, which can be harbingers of a serious life-threatening disease, or they may be coming from your vascular anomalies. So in order for you to have a good orbital examination, you should have good history and physical examinations. Okay, so often we do the evaluation using the 6 P's. So the first P is you assess for pain. Then you check for palpate the eye. No? So do palpation. You check for pulsation. So either through palpation, you would notice vessels palpating, or you may use your stethoscope actually to put it on the eye and hear any bruit. Next is proptosis, progression, and then periorbital changes. So these are the 6 P's in doing your orbital examination. And among them, um, proptosis is the most common reason for consultation. So that means proptosis or a bulging eye, no? Exophthalmos. So a bulging eye often is one of the most common cause for an eye examination. So if there are any problems with my slide or audio, just tell me, huh? Or you can write your questions or comments at the chat box. Okay, so since the orbit is a confined space, any increase in orbital volume leads to globe displacement. So as seen in this photo, the eyes looks proptose, or it's a full, filled. So this is actually an eye moving forward. So this is known as your proptosis, forward protrusion of the globe, which can be a hallmark of a orbital disease. Next is exophthalmos. So exophthalmos is the reverse of a proptosis. Exophthalmos is the same as proptosis. So when you hear the word exophthalmos, this is a specific displacement. So this description is often associated when you hear of the condition called Graves' ophthalmopathy. So it's a thyroid eye disease with a globe displacement. So often it's called an exophthalmos. So ophthalmos meaning it's the eye protrusion. Now because proptosis can be used in other parts of the body or other description. But when you hear ophthalmos, then that means it's the eye that has a problem. Pseudoproptosis, on the other hand, is proptosis in the absence of an orbital disease, or there's no actual globe displacement. No, it just looks displaced, but when you do measurements, it's normal. Okay, so as mentioned, the orbit is a confined space, so confined by your bones. So that means your bones can limit your displacement. So a common cause of proptosis are masses. So when the mass is pulsating, it is likely to be vascular. It is likely to be a vascular lesion, or if a cerebral pulsation is felt, and maybe there is a bone defect. So if you remember orbital trauma and you have a floor roof fracture defect, then you might feel cerebral pulsations. So the limitation of eye movement results in diplopia or double vision. Causes of the limitation might be a problem in the muscle itself, such as those in congenital diseases, interference such as an entrapped muscle in a fracture, or from trauma, or the cause may be neurologic. So very common trauma, especially for motor vehicular accidents. If you remember the discussion previously, then the muscles can be entrapped, or the muscles can be damaged, or if a patient has stroke, no, so loss of vascular supply and nerve supply leads to limitation of your ocular muscle movements. Eye pain is also a common complaint, no? And it's always a variable sensation. So it depends on the patient. That's why you ask for a pain score and you ask them to describe describe the pain. So depending on the location, the causes of pain can be inflammatory. It can be due to a rapid expansion of the orbit, or it can be an infiltration of your sensory nerves. So here in the photo, so you see that there is a limitation of the right eye. So your left eye was asked to move or look at the right gaze, but there is no movement of your right eye. Also, if you look closely, there's a shadowing, over the periorbital area. So if you look at very closely, it's not just shadowing, but actually the globe is inward, so the patient has a deep socket. So the globe is moved backward, not inward. So it's a deep socket. That's why there's like a shadowing. Your roof, is forming a roof good over the orbit. So there's a shadow towards the inferior area. Okay, so imaging for orbital diseases. So number one, we use radiographs, or X-rays. So this is very helpful when CT scan is not available. So aside from identifying fractures, they are helpful to rule out metallic foreign body. For the orbit, to be specific, we use different views to help us locate what we are looking for. And one of the most common views requested is your skull APL. So anterior, posterior, and lateral views. You can also request for Waters view and Caldwell view. So Waters view is used because it's best used to view your orbital roof and floor. And then your Caldwell is best view for your superior and lateral orbital rim, medial wall, ethmoid, and frontal sinuses. So basically, Caldwell is more for your sinuses, and then Waters view for your roof and floor. Your CT scan or your computed tomography detects foreign body or calcifications, soft tissue lesions, and bony details, among others. So this is commonly requested for orbital trauma because it provides better bone detail. When you compare the CT scan to the previous photo, although X-ray is very quick and very much available, but examination is much more difficult if you're not used to it. That's why CT scan is a very good tool. Aside from bones, it also detects acute hemorrhages. It gives us a better view of the sinuses and for other forms of trauma. So it can provide multiple segments or cuts in the different parts of the body or the globe. So unlike your X-ray, it only gives you one cut, but in different views. But it is also limited. But in CT scan, so you can have different segments viewed, and then you're able to identify diseases, defects, or other pertinent details. So one advantage of your CT scan is in between your X-ray and your MRI. So when compared to an MRI, it uses a shorter time for imaging and it is less expensive. So when we have our CT scan, we have the different views: sagittal, axial, and coronal views. So when we describe CT scan, we always start, this is a CT scan showing the axial view. So we have to describe what view we are looking at. Then sometimes all this view combined into one is called 3D reconstruction. So this gives us a reconstruction or a 3D view out of all the scans that you did. And then sometimes we also use contrast to better see details, to check for the vascular abnormalities or detect any tumors. Okay, so commonly we use non-contrast or without contrast, but for tumors and for better tissue details, vascular lesions, then you use contrast. So the magnetic resonance imaging is also similar to your CT scan. It provides or it has an advantage for providing better soft tissue views for your orbital apex and the posterior fossa detail. There are also no artifacts from the bones, but it provides us poor details of the bone. So it takes longer to perform and it's more expensive. And not all patients are able to undergo CT scan. So the contraindications include presence of metallic foreign bodies, a patient with pacemaker, or patients having an aneurysm clip. Yeah, so remember these three contraindications. So many patients have other conditions, no heart conditions. So always ask for the history of having a pacemaker. Okay, so moving on to the different orbital diseases and disorders. So you have TED. No? So TED is an acronym that we commonly use in ophthalmology. So instead of ideas worth sharing, then this is a disease worth spreading or talking about. So TED in ophthalmology is known as your thyroid eye disease. So this includes your Graves' ophthalmopathy or orbitopathy, or it can also be known as your thyroid-associated ophthalmopathy. This is an autoimmune disease with a spectrum of ocular manifestations. The pathology is believed to begin with the activation of the orbital fibroblast by antibodies. So this is directed to the thyrotropin receptors. Once activated, the fibroblast leads to an increased production of mucopolysaccharides, which will then accumulate in your extraocular muscles. So, in addition, these fibroblasts differentiate into adipocytes and myoblasts, which will eventually lead to orbital fat expansion and fibrosis, respectively. Okay, so basically, it's an autoimmune disease associated with a thyroid disorder, often manifesting as globe displacement, inflammation, and extraocular muscle restriction. So TED is the most common cause of a unilateral and bilateral proptosis in adults, and women are affected 8 to 10 times more as compared to male. Okay. So remember, this is the most common cause of unilateral proptosis. And then as mentioned, it's a thyroid eye disease, and this is commonly associated with a Graves' disease. So patients can be hyper, hypo, or euthyroid. And so even if you have normal thyroid levels, you still can have a thyroid eye disease. But this disease is more common in your hyperthyroid patients. So about 90% with hyperthyroidism can manifest as TED, and about 8%, 7 to 8% with euthyroid, and those with hypothyroid, about 3% can present with TED. So these are the common findings. So 90% will present with eyelid retraction. So if you look at the first photo, both your upper and lower eyelids are expanded. So when you compare it to the left eye, medyo open ang right eye. No? So that means your eyelids are retracted. So it's opening up. 65% of patients with TED will present with proptosis, no, or bulging of your globe. Then followed by lid lag on down gaze, which is known as your von Graaf sign. So when the patient looks down, the eyes or the upper eyelid will slowly move, no, when you compare it to the other eye, or the eyelids will slowly close, no. So that is called your lid lag on down gaze. On the middle photo, you have what we call an exophthalmos, no? So meaning the eyes won't fully close. So if you look very closely on the right eye, you would see a little bit of scleral exposure beneath your eyelashes. No? So there's a white segment. So that means the eyelids are not fully closing. So severe lag of ophthalmos can lead to corneal exposure. So that means the eyes won't fully close, and so your cornea can be exposed to the environment, so it will cause diseases of the cornea. So once you have corneal exposure, then your patient can have ocular surface discomfort. On the last photo, you would see again, no, extraocular muscle restriction. No, so the eyes are not moving in the same way due to a restriction of either your superior rectus, inferior rectus, or your lateral rectus. But even your obliques can be involved. So once you have eyes on different gazes, then you would have double vision. But if your eyes are looking straight, it's normal. You can have normal vision, but on gazes where the eyes won't move, then you will have diplopia. Okay. So this is your HL view of your CT scan with an HL view showing your right and left eye. No? But if you notice, one of the muscles, no? So is this the left or right eye? Anyone? Do you know if this is the left or right eye?
Right eye, Doc.
You know, so it's the left eye.
Ay, sorry, Doc.
It's okay, no? So it's the left eye. No, so when you look at eggshell view, you're looking at the patient at his feet, no, at his or her feet. No, so nag-lie down siya, then you're looking at from the feet. So what's on your right is the patient's left eye. What's on your left is the patient's right eye. So here you see that on the patient's left eye, the medial rectus is very enlarged. No, so more siya drumstick. So if you compare it to the other muscle, no, on the other eye, so the other eye is smaller. And then your inflammation is only at the middle part. So it's sparing your origin and your insertion. So that means enlargement spares the tendons. So as mentioned earlier, the pathology includes fibroblasts producing mucopolysaccharides, which eventually leads to increased water contents of the muscles. So among the muscles, the rectus muscles are commonly affected, starting from your inferior and medial rectus, and then later involving the other muscles. So ang mnemonics is I am slow. So inferior rectus first, medial rectus, and then your superior rectus and lateral rectus. And the last muscles to be involved are your obliques. So I am SLO. So I'm slow. So later when the muscles are inflamed and we don't treat it, it becomes fibrotic. So it would further lead to ocular muscle restriction. If you look at the photo as well, the muscles are inflamed. So if all muscles or most of the muscles are markedly inflamed, so meaning very severely inflamed, and if you remember the anatomy, all the rectus muscles originate from the optic or from your orbital apex. So in your orbital apex, you have your annulus of Zinn, no? So where your optic nerve exits or your optic nerve originates. So when the muscles are severely or markedly inflamed, this inflammation or enlargement can compress your optic nerve. So which will lead to patients having decreased vision. So what you would know is that patients would have um, eye muscle movement restriction. They not only have double vision, but for severe cases, they can have loss of vision. So a very short mnemonics, no, for patients with thyroid eye disease, no, from early symptoms to worst symptoms is your nose specs, NOSPECS. So number one is that patients, although they may have thyroid eye disease, they may have no signs or symptoms. Later, they would only have signs, no? So such as your upper lid retraction without any lid lag or proptosis. Then later, they may develop soft tissue involvement, so meaning there is more edema, which can now affect your conjunctiva and eyelids. And then they would have proptosis, no, or globe displacement, later evolving to extraocular muscle involvement or restriction. And then you would have lag of thalamus, so you're not able to fully close your eyes, or the eyes are more proptosed, no? So the cornea is now exposed to the environment. It can't be covered by your eyelids. So you would have decreased vision later. No? So both decreased vision is initially due to a corneal involvement, but later once the muscles are very inflamed and it now compresses your optic nerve, then you will have sight loss. Okay, so that's your mnemonics for your thyroid eye disease. No specs. So how do you manage thyroid eye disease? So number one is to keep your thyroid abnormality under control. Okay, so that's the very core of management. No, so treat the underlying cause. So in this case, it's a thyroid eye problem. Then you treat your thyroid abnormality. So we refer these patients to an endocrinologist. No, so that is the main problem, but they have eye symptoms. That's why they are referred to us, no, or the other way around. So kita ang first makadetect that the patient has eye problems, and then on workup we noticed a thyroid. We refer to an endocrinologist. So management can be medical, surgical, or even use of your radiation. So remember this photo, no? So this patient has lid retraction in both eyes, and probably the eyes are also proptosed. No? So in vernacular or Bisaya, it's called budlat. So the eyes are very exposed. So normally you would notice that the upper eyelid covers the upper part of your cornea. No? But in these patients, now all the cornea is exposed and most of your sclera is exposed as well. So once you treat your patients, then you would see a significant change. No? So the eyelid positions are back to normal. So the upper cornea is now covered by your normal eyelids, and there's less exposure of your conjunctiva. Okay, so mainly it's just taking control of your thyroid problem with medical intervention. So when there's persistence of the condition despite medical therapy, or persistence despite therapy, then we suggest surgery. So this is the order of surgery we do for TED. So we decompress the orbit, we do strabismus surgery, or correcting the muscles. And if there's persistent lid problems, then we do lid surgery. In some cases, some patients, although they have thyroid abnormality, this can still be a self-limiting disease. So for mild Graves' ophthalmopathy, you would often just have ocular surface problems, so we can lubricate the patients with artificial tears. There's also a time where, since it's autoimmune, so the disease can keep on recurring. It can be active. So there will be exacerbations, periods of exacerbations, and periods of remission. So it's not just a one-time thing that TED happens, you medicate, and it's going to be back to normal. So it can be back to normal for a time, then it can reflare, and again present with TED. Or sometimes you can control it for so long, or sometimes we will be having difficulty in controlling the disease. So once you have moderate to severe Graves' ophthalmopathy, then immunosuppression may be required. So more than just surgery, more than just medications with steroids or your anti-thyroid hormones, immunosuppressant therapy would be required. So that won't be discussed here now. So we're only tackling on the basics of the management for thyroid eye diseases. For patients with sight threatening, especially those na the optic nerve is already compressed, we give high dose of steroids to decrease the inflammation, and then we do surgical decompression in order to save and protect the optic nerve. If we don't do it, then you would have what we call a compressive optic neuropathy. So the optic nerve is compressed by the extraocular muscles secondary to your Graves' ophthalmopathy. And so if you also have loss of function of your extraocular muscles, loss of nerve supply, then you would have severe corneal exposure, or severe corneal problems. So in ophthalmology, we call corneal problems, especially secondary to inflammations, as keratitis. So when you hear the word kera, then that likely represents or talks about the cornea. Okay, so as mentioned, we have a staging for your thyroid eye disease. So before we do surgery, we advise the patients to have at least 6 months of being controlled. So achieve 6 months of disease inactivity and have a euthyroid or normal state before we suggest surgery. Unless the control is an emergency, then we can do surgery. Other than that, we have to make at least the patient stable for 6 months. So the first thing we do is orbital decompression. So this is done to relieve proptosis. And this is indicated when patient is medically uncontrolled or is having an unacceptable aesthetically looking eye. Second surgery you do is strabismus surgery, which will correct your ocular deviations, correct your extraocular muscles. And then lastly would be to do your eyelid surgery. A differential when you have lid retraction, when patients have normal thyroid levels, you can consider NSOI, or non-specific orbital inflammation. So this is one of the most common differentials when you have thyroid eye disease as one of your primary problems. Okay, so as the name implies, this inflammation is idiopathic, which occurs rapidly in one eye and characterized by pain, periocular and conjunctival edema, proptosis, and diplopia. So before, when you hear the word orbital pseudotumor, this is just the previous term for your NSOI. So they just mean the same thing. Okay, so the inflammation can be diffused or localized, and it can involve any orbital structure. When the extraocular muscles are involved, it's known as myositis. When your lacrimal glands are involved, it's called dacryoadenitis. And when your optic nerve sheath is involved, it's known as your optic perineuritis. So those are the different forms of your NI. Okay, so if you look at the two photos, no, so on the right side, no, so this was the previous photo of the patient with TED. No, but when you compare it on the left CT scan, you see that there is more uniformity in the inflammation of the muscles. No, so including the tendons. So when you see a more diffuse inflammation involving the tendons, then this is most likely your NSOI. So compare it to the TED CT scan. No, so the tendons are thinner for TED. So NSOI is tendon involving, while your TED is tendon sparing. So I usually think about TED as tendon exempted disease. So that means when you do CT scan, tendons are exempted from inflammation. Okay, so the first line in management for your NSOI is steroids. No, because when you do workup, thyroid hormones are normal, so you don't need to treat them, but instead you treat the inflammation with steroids. So the recurrence or a lack of treatment response is very common. No, so an alternative treatment will be used, such as your immunosuppressants. And lastly, surgery is reserved only to do biopsy in order for us to establish a diagnosis. So I think in some cases when the medical management is not enough and patient has severe eye problems leading to pain and loss of vision, then often an eye removal surgery is done. Okay, so before we move to orbital infections, do you have any questions with regards to thyroid eye disease and your NSOI? None?
None at all.
Okay. So next are orbital infections. So I think in all departments, nor in all specialty, infections will always be a common cause of consultation. Okay, so does anybody in the class can describe this photo and give an assessment or diagnosis? Any volunteer? Wala. Okay, so this picture shows orbital cellulitis. So this has been discussed no, as one of the ophthalmic emergencies. So this is often due to bacterial infection involving the structures or area posterior to your orbital septum. Orbital cellulitis is also known as your post-septal cellulitis. So if TED is the most common cause of proptosis in adults, then orbital cellulitis is your most common cause of proptosis in children. Okay, so immediate treatment is essential. So that's why it's one of the emergencies or urgent cases for ophthalmology, because a delay in management leads to a myriad of complications. So majority of your orbital cellulitis arise from acute sinusitis, often due to Staph aureus, or in patients with chronic sinusitis, often consider anaerobic organisms. Okay, so going back to the anatomy, always remember that orbital septum is a very important structure. So it's a structure that prevents extravasation of blood, infections, and protects your posterior orbital structures. So when you have preseptal cellulitis. So this is different from your orbital cellulitis. So preseptal means the infection is located anterior to your orbital septum. Okay, so since it's just anterior and your orbital septum is intact, then it spares the globe. So here, your major cause or risk factor in developing this infection is skin trauma. And again, one of the most common organisms are your Staph aureus. So patients still present with swelling, no? So eyelid edema and erythema. They may also have a little bit of pain, and some patients would have fever being an infectious process. So how do you differentiate your preseptal versus your orbital cellulitis? Okay. So once again, your preseptal cellulitis includes edema, erythema, pain, and fever, which may be present as well, for your orbital cellulitis. However, your orbital cellulitis is characterized by other factors, or other presentations. So patients would often present with proptosis, chemosis, swelling of your conjunctiva. Patients would have limitation of eye movements, and then on CBC, you would see leukocytosis. So basically, your preseptal cellulitis can be an initial stage of your orbital cellulitis. Okay. So if you look at both photos, so it's clearly distinct. No? So for preseptal, it's just mainly involving your adnexa, nor outer structures. But once the eye itself is involved, especially with conjunctival swelling or chemosis and decrease in eye movements, then mainly consider it as developed into an orbital cellulitis. So when your orbital cellulitis involves both eyes, so that means it is a critical part. So it can now be a critical disease. So consider extension to the cavernous sinus when both eyes are involved, because the cavernous sinus can produce contralateral orbit involvement, trigeminal nerve dysfunction, and a more marked systemic illness. Okay, so often it's lateral, but once it's bilateral, consider involvement of your cavernous sinus. Okay, so once again, CT scan is a good marker or a good tool or a good imaging when we do orbital diseases. So the use of CT scan or even an MRI can provide essential information, such as the source of infection and the extent of our cellulitis. So we often do a CT scan to assess patients, especially when they have orbital cellulitis. So if you look at the photo on preseptal cellulitis, the extraocular muscles are uninvolved. So they're smooth and looks normal in contour. But for orbital cellulitis or the scan on your right side, you see that there's some stranding or there's some grayish area located within the muscles or beside the muscles. So that means inflammation has reached that part, especially in this case, it's involvement of your medial rectus. Okay. So again, one of the common causes is orbital. One of the common causes is presence of sinusitis. So aside from looking at your orbit, also look at other structures such as your sinuses. So in this case, you have a ethmoidal sinus filled with this inflammation, then most likely is adjacent to the medial rectus, and this is the likely cause of your orbital cellulitis. And then we use landmarks, such as our bones. So the bones, we use or we draw an imaginary line connecting the bones and assess the globe. So in this case, the globe is fructose. So normally, that imaginary line should intersect the middle part of the globe. Now here is mostly at the posterior part. So that means that this eye is moving forward, or is fructose. And then if we compare it to a preseptal cellulitis, which does not involve the posterior aspect, so look at the imaginary line, it usually bisects the center part of the globe. Okay, so on these scans, then we know that the patient has proptosis when the patient has orbital cellulitis. So in terms of treatment, it's very different. So for preseptal cellulitis, it's just mostly giving oral antibiotics and closely monitoring the patient. However, for orbital cellulitis, is initiated even before identifying the causative agent. So we can often get nasal, cultival, and blood cultures to help us clinch the etiology. But even while waiting for the results, broad spectrum antibiotics should be given. So often, these patients are admitted for IV antibiotics to give them broad spectrum and anaerobic coverage, because you don't want the infection to spread through the cavernous sinus and affect both eyes. So when you have presence of sinusitis, then it's always good to do consultation with ENT. And for those that has poor response with antibiotics, or patients already having compromised vision, then the drainage of the abscess is one of the considerations in the management of these patients. Okay, next is your dermoid and epidermoid cyst. So these are not gross inflammations, but these are abnormalities that you see within your adnexa. So dermoid and epidermoid cysts are not true neoplasms, but are benign choristomas. So this means that they originate from your surface ectoderm and is lined by keratinized epithelium. Okay, so dermoid cyst means that it contains epithelial structures, such as your keratin and hair. So you would often hear keratin associated with teeth, but it's not seen, or it's not located, or it's not found in this of the eyelids. And then epidermoid it's filled with keratin but without any dermal appendages. So if you look at the photo, you would see that your dermoid cyst is located most commonly at your lateral brow, often located within your frontozygomatic suture. Okay, so here you would see that there's a bulging structure on the lateral aspect of the brow or on the temporal area. Then either we can request for an MRI or a CT scan. So with the MRI, you would see that there's a well-defined round mass located at the temporal aspect. So this is one of the characteristics of your dermoid cyst. Often when your cyst is becoming very large, it may also sometimes produce bony defects. So the mass may cause pressure when it's slowly growing. So if you look at the CT scan, so the mass is enlarging and the bones looks a little bit bent. Now if you look at the arrow on the right corner, so the arrows show that which are usually diagonal, curvilinear. Okay, so one of the treatment is either we can do observation, or some patients would often need surgical excision. So this is an en bloc surgical removal and preservation of your cyst. So you would see that the cyst, the contents, has some inflammatory reaction, and it can lead to the bony defects, increase in pressure if not removed early or if it's slowly progressing. Next are some red spots that you may see in babies or young children. So this is known as your capillary hemangioma. So this is the most common benign tumor of the orbit and the periorbital area in childhood. So once again, it affects girls more than boys, in about 3-to-1 ratio. So since it's red, or it's mainly vascular, so the tumor is composed of anastomosing vascular channels, which about 30% may be present at birth, but later, it's often usually noticed in the first. So if you see dark spot, so we often call it a nevus, or in dialect an aum. But if it's red, then more likely capillary hemangioma. So often we can say it's a strawberry nevi, when it's very superficial. But if it becomes deeper, instead of being red, the color of the skin may be a little bit bluish. So capillary hemangioma can appear in different areas, involving the orbit, but mostly on the eyelids. So again, it can be a small isolated lesion, or it could be a large disfiguring mass. So 30% often noticed at birth or within the first year of life, and then 90% of them are almost seen as apparent before 6 months old. And then it enlarges during the first year of life, then gradually slow or decreases over 6 to 7 years. So initial treatment or initial thing to do would be just to observe and see if regression is happening. So if you compare two photos, one lesion is superficial and one lesion is deep, which causes disfiguration of the eyelids. So lesions within or inside the orbit can cause proptosis, strabismus, optic neuropathy. But for patients with lesions in the eyelid, it can either cause astigmatism, or like the top photo, it's so heavy, it closes the eyelids. Patients would have difficulty opening. Look at the bottom photo as well. Right eye has spontaneous opening. On the left eye, a little bit of very small opening. So patients or babies are not able to see well. So they occlude vision, and if it happens, patient may not have well-developed vision, so which can lead to amblyopia, or what we know as a lazy eye. Okay, so for patients who have lesions that leads to vision, then observation might not be a good plan for them. So once again, so it's common in the first 3 to 6 months, but it grows rapidly. 30% resolved by when the patient reaches 3 years old. More resolved by 7 years old. So as mentioned, 6 to 7 years, it will regress. But not everyone will have regression. So about 75 of patients with capillary hemangioma would have its resolution by 7 years old. So continuous monitoring is done and imaging is requested to rule out extensive orbital diseases until the lesion becomes small. So it's very good today that we have technology such as our phones, so we can keep on tracking. We can keep on taking pictures and tracking the size of our capillary hemangioma or even different lesions. So treatment number 1 is we can do systemic or intralesional steroids. So this is our first line therapy. Second is you can give systemic beta blockers. So this is an alternative. So one of the common medications that we can give is your propranolol. And lastly, if the steroids and beta blockers don't work, then patients can undergo surgery, such as doing laser treatment or even excision of the mass. So surgery is often recommended when it's refractory or not responding to treatment, or for children, it compromises their vision. So you need the child to have good eye opening so that they may be able to see clearly and they may develop their vision better. Okay, some lesions are not seen, no, with the naked eye, no, but there will be lesions inside the orbit, and so we need imaging. And one of these lesions are your cavernous hemangioma. So cavernous hemangioma is the most common benign orbital tumor in adults. So this occurs frequently in women as well. Okay, so the lesion is located within the muscle cone and it produces subsequent proptosis. So if you look at the CT scan, there are two round shaped structures on the left eye. So one of it, no, the inner structure is your cavernous hemangioma. Okay, so as mentioned, it's located within the muscle cone. You have to detect or locate the muscles and see the lesion within or entrapped within the muscles. So aside from proptosis, no, or eye globe position forwarding, patients may also develop hyperopia or nearsightedness, or the back parts. When we do fundus examination, the retina looks folded or has striations. So unlike your capillary hemangioma, these lesions do not, no, regress spontaneously. So these deeper lesions will continuously produce problems. And therefore, no, surgery is indicated when the patient is symptomatic. So we excise, can do when it's so when it's really at the back part, no, especially in the orbital apex. So this becomes a surgical challenge. Next is your rhabdomyosarcoma. So if you look at these patients, they may look like preseptal cellulitis. They may look like your capillary hemangioma. So we must be keen, or we must be observant, and we must have different differentials. So rhabdomyosarcoma is a common primary malignant tumor of the orbit in children. So this often occurs before the age of 10 years old. So these patients would have rapid growth of the mass associated with proptosis and downward globe displacement. Okay. So if you look at the photo, no, the right eye has a severe, no, eyelid mass, and the position of the right eye is very displaced. No, so since it's mostly in the upper eyelid, then the mass would be pushing the globe downwards. So the tumors may destroy adjacent bone and spread into the brain. So treatment depends on its staging. So treatment include radiotherapy, chemotherapy, and with or without surgery. Okay, so if surgery is to be done, surgery is used to be the primary treatment by doing exenteration until about 1960s. But even so, with exenteration or removal of the mass and including the eye, mortality rate was still high. So about 70% of children with rhabdomyosarcoma still end up being mortality despite removal of the tumor and the eye. So due to the high incidence of mortality, technology, no, prompted the use of radiotherapy and chemo as the main treatment for rhabdomyosarcoma. So now the prognosis is about 90% with your treatment. So as compared to radiotherapy, chemotherapy is more appropriate for children because radiotherapy produces more complications. Okay, so when you see those cases, those are mostly localized tumors of the eyelids, no? But other cancers or other diseases can have metastatic tumors. So we have a different primary tumor, and then some tumors are noted within the orbit. So when you have a different site of your tumors, then they reach the orbit through hematogenous spread. So the tumors are commonly located into the choroid and in the orbit. So basically, this area has a very good blood supply. So these are the areas where you have your metastatic tumors. So adults often have your breast, no, for females, and lung and prostate cancer for males. So always remember to check for lymphadenopathy, and then also look at the eye if they have tumors included or tumors are present in the eye. In children, one of the common tumors would be your neuroblastoma. So often they will have spontaneous periocular changes. So these are more um, obvious. So when the patient has a different tumor and then a secondary tumor in the eye, so often a neuroblastoma. So treatment for metastatic tumors, no, so they respond well to radiation and chemotherapy. If it's small and localized, then surgery is one of your treatment options to excise these tumors. But also remember, so since these are tumors or cancers, and it's already metastatic, then they may have a poor prognosis, no, or we consider poor life expectancy, unless treated early, detected early, and then later, once there are advancement in cancer therapy, then probably survival and prognosis would be better. But since often if it's metastatic, chances are it's already a severe disease. Okay. Um, Before we proceed to the eyelids, do you remember eyelid anatomy? So if not, you have to review. Okay. So once again, the eyelid is a thin structure composed of skin, muscle, and fibrous tissue, which generally protects the eye. Okay, so the main muscle of the eyelids are your orbicularis oculi and your levator palpebrae superioris. Okay. So your orbicularis oculi is innervated by cranial nerve 7 and its functions to close the eyelid, while your levator palpebra superioris and your upper eyelid and your capsulopalpebral fascia of your lower eyelid are the principal retractors, and your upper eyelid is innervated by your cranial nerve 3. So your levator palpebrae superioris opens your eye. Okay, so the lids are well formed or has a supporting structure known as your tarsus. So this is a rigid collagenous plate, and it is attached to your orbital rim via your canthal tendons. And the most posterior covering or mucous membrane of the eyelid are your conjunctiva. So this contains glands essential for lubrication of your ocular surface. So eyelid crease, can be differentiated for Asians, Caucasians, and different people. So your eyelid crease usually present in the mid upper eyelid in Caucasians. And this also represents the levator aponeurosis fibers attachment to your superficial layers. So you'd notice that in Asians, the crease is lower or absent. So here, is a photo of not a normal, no, but a person showing your eyelid crease, no, so the folds noted in your upper eyelids. But in Asians, you would see that it's lower or absent. Okay, so you would notice na lower ang position. So for your Chinese friends or those with small eyes, then look at your eyelid crease. Okay, so let's now talk about common infections and inflammations of your eyelids. So number one, you have your hordeolum or sty versus your calasion. So these are the two common infections that you would see on patients with eyelid problems. So these are the difference, no, as seen in your slides. Your sty, basically your sty and hordeolum are the same. No? So those are just different names. And calasion, similar, no, but different. But in vernacular, when you hear patients say they have binggit or bujinggit, no, so they both refer to calasion and a sty. But for us, medically inclined, you should be able to differentiate your sty versus your calasion. Your sty is an acute inflammation of your meibomian glands or the glands of small and size. No, so remember these structures. So they present with pain, redness, and swelling, which are your principal symptoms, and they can just be managed conservatively, no, through warm compress or giving your topical antibiotics. So for patients whose sty are unresolving with your management, surgery is done using or doing incision and drainage. Versus a calasion, which is a sterile, focal, and chronic inflammation due to obstruction of your meibomian gland. So basically, your sty is acute, while calasion is chronic. And then mainly, your calasion is sterile due to obstruction of your meibomian gland. So often, it can be a complication or a late stage of your sty. So this begins with mild inflammation and tenderness, just like your sty, eventually leading to become firm and painless. And this may persist over weeks or months. So if it's not relieved, then you do curettage and remove the abscess located within your calasion. Next is blepharitis. No, when you don't see tumors or lumps, it's just a generalized inflammation of your eyelid margin. Okay, no, so blepharitis is a chronic inflammation of the eyelid margin, often due to staphylococcal or seborrheic in etiology. Symptoms include irritation, burning, itching of the eyes and eyelids. So these are the common, or these are the chief complaints of your patient. So when you look at patients more closely, the eyes are red rimmed. No, it's because it's the lid margins that are inflamed. So often when we look at the slit lamp, no, or more in a zoomed view, we would see a discharge, no, noted on the eyelids, especially on the eyelashes. And this discharge is what we call as collarettes. No? So these are crusty golden discharge located within the base of your lashes. So these are red eye, red rim or inflamed lid margins plus your collarettes. These are what consist of your blepharitis. So treatment, no, is just lid hygiene, so cleaning your eyelashes or eyelids. And for persistent or for those with staphylococcal infections, then antibiotic ointment can be given. Okay, so those three diseases are the most common, no? But there are other eyelid abnormalities that we won't be going deeper, won't be having a deep discussion. So some abnormalities include your ectropion. So on that photo, you would see that the eyelids no, are outward turning. As compared to an entropion, the eyelids are inward turning. So those are two other abnormalities about lid malpositions. And then if we look at the eyelashes, we also have problems. No, we can call it trichiasis when the eyelashes are misdirected towards the cornea. And we call it distichiasis when you develop so much or so many rows of eyelashes when compared to normal. No, so look at the last photo for distichiasis. Look at the upper eyelid. No, so there's so many here. No, so that means the patient has developed a different row of eyelashes. And then the bottom photo, no, be careful. No, so some patients or some students misinterpret or mix proptosis from ptosis. Okay, so proptosis is forward displacement of your globe. But when you hear the word ptosis, no, Ptosis, this is your eyelid abnormality. No, so the eyelid is low in position. No, so that means your eyelids are not fully opening. So in that photo, you have ptosis on the patient's left eye. No, so it's not fully opening, so it's just halfway. So there's also sometimes loss of the lid crease. So when you have ptosis. So next are benign tumors of your eyelids. So benign tumors are acquired cellular tumors that are atypical. They enlarge slowly, and they have little to no invasive potential. Okay, and they also have no metastatic capability. So one of the common tumors that you would see are your skin tags. No, so skin tags are in medical term known as your squamous papilloma. So this lesion is composed of a focal hyperplasia of stratified squamous epithelium of the epidermis. This appears as fleshy colored lesions with irregular surface, which can be single or multiple, and can either be sessile or pedunculated. So such lesions are just observed, or if it's not pleasing, or they can undergo excision. Next are your seborrheic keratosis. So seborrheic keratosis is due to proliferation of benign basal cells. This is predominantly seen in the middle age to older individuals. So these are like wart-like in appearance. So it's called a dome shape or verrucoid appearance. They appear as greasy or stuck-on lesions. They are gray-brown in color. They have a crusty surface. And again, no surgical excision if aesthetically bothersome. So some lesions, similar to seborrheic keratosis, is your verruca vulgaris. So when you have this condition, this is often caused by your HPV virus, human papilloma virus 6 or 11. So this appears as a small non-pigmented papule with digitated surface, and treatment is by excision or cryotherapy. So this verruca vulgaris is known to recur. A volcano-like or crater-like lesion is known as your keratoacanthoma. So this is a low-grade tumor which closely resembles a squamous cell carcinoma. So this is a rapidly growing single nodule which develops over a few weeks. So it's umbilicated with a distinctive crater filled with keratin plug. So there's spontaneous involution after 6 months, and it will leave an atrophic scar. Surgical excision is your treatment of choice. Do you know who this person is?
Wolverine.
X-Men.
Oh, specifically who?
Hugh Jackman.
So Hugh Jackman. So do you know the significance of Hugh Jackman to our presentation today, or to our lecture today? Okay, no. So we'll stop here. No, so that would be your assignment. So know know why Hugh Jackman is part of our next discussion. No, so what disease does he have? Okay, so that will be your assignment. All right, so I think that would be the end for today's lecture, and then we'll continue on Wednesday. So I'm saying Wednesday because I won't be available for the examination, so I will move your exam on Friday.
Yay!
No, pero the coverage would still be your previous topics. So orbit is not included for your examination. Okay, so anatomy, ocular examination, and emergencies will be on Friday. Okay, so are there any questions, clarifications? So if none, we'll still be meeting on Wednesday, still online, and then we'll have the examination on site on Friday.
Thank you, Doc.
Okay, thank you. If no more questions, have a good
Thank
day.
you, Doc.
Thank you, Doc.
Thank you,
Thank you,
Doc.
Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.